Hello, everybody. I'm glad to be joining you for the virtual Parkinson's walk. I have my shoes ready to go, and I'd like to walk through Parkinson's disease medications with you today. And we're going to concentrate on the motor symptoms of Parkinson's disease. So, those are the ones associated with movement. A little bit about me. My name is Jason Strow, and I'm the Mid Atlantic Regional Director of Pharmacy for Encompass Health, and I'm also the Area Director of Pharmacy for Tidelands Health Rehabilitation Hospitals in Myrtle Beach. So let's talk a little bit about balance. So, balance is very important, and with Parkinson's disease, it's extremely important. So, we have two chemicals in the brain, we have dopamine and we have acetylcholine. When those are in balance in your brain, you're actually going to not have Parkinson's disease. So, what happens in Parkinson's disease is we have a decrease in dopamine. So, what happens is you have that decrease in dopamine, and the acetylcholine is no longer balanced with the dopamine. And that's what causes the symptoms of Parkinson's disease, especially the movement related symptoms that we're used to seeing more commonly. We have non motor symptoms of Parkinson's disease as well, but we're not going to be discussing those as in depth today. So keep in mind that the brain chemical that we are very worried about is the decreased amount of dopamine. And it's also going to need to become balanced again with acetylcholine. So in Parkinson's disease, this is kind of the picture we're looking at, and we're wanting to get back to the picture of having dopamine and acetylcholine on that balance again. So let's talk about ways we can restore that balance. So the first way is we have our brain chemical or neurotransmitter called dopamine. We have medications that mimic dopamine or break down into dopamine in your brain. So our ones that mimic dopamine are carbidopa levodopa. And carbidopa levodopa is kind of the mainstay of therapy for Parkinson's disease. And it goes by the brand name of Cinemet, Cinemet CR, or Rytari are the ones that you'll hear about more commonly. Duopa is an interesting one because it's actually a gel that goes through a pump and it goes directly into your intestinal system. It requires surgery to be able to use the pump, and some patients will elect to have that type of therapy. We also have a few others, and these are called our dopamine agonists. And agonists mean like that they act like dopamine. So we have pramipexole and ropinirole, which are those. Next, we have apomorphine, and it's an injection. It's mostly used for rescue of, of symptoms of Parkinson's disease. So, if a person starts showing more symptoms of Parkinson's disease and they're not able to get back to their baseline, apomorphine may be a way for them to get there. So, next, we have a way of making more dopamine available. So, there's different things in the body that will break down dopamine, and those are typically called enzymes. And one of those is called catecholamine O methyltransferase, or COMT. So we have two COMT inhibitors, and inhibitors stop COMT from working. So we have entacapone and tolcapone. So they go by the brand names Comtan and Tasmar. So the other enzyme that breaks down dopamine is monoamine oxidase. So we have monoamine oxidase inhibitors that stop monoamine oxidase from breaking down dopamine. So we have selegiline and rasagiline. Selegiline was the first one to come out. There's two different types of monoamine oxidase inhibitors out there. So selegiline is what we call a non-selective monoamine oxidase inhibitor. So what that means is you have to worry about the other things that monoamine oxidase is going to break down. And one of those is called tyramine. And tyramine is a chemical that is in food. And with tyramine, you see it in different types of cheeses. And you might find it in meats such as pickled meats, sometimes in sausages, and also in beer. So with selegiline, you have to have a discussion about diet. Rasagiline came along and it's a little more selective for the type of monoamine oxidase that doesn't also break down tyramine. So with rasagiline, you don't have to worry as much about dietary restrictions. And we also have sulfonamide, which is newer on the market, or Xadago. And once again, it is going to be prevent the breakdown of dopamine. Next, we have drugs that decrease acetylcholine action. So what that does is it helps bring our balance back. So we have trihexyphenidyl and benztropine, which have been used in the past for this reason. And keep in mind that the drugs that make more dopamine available and that decrease acetylcholine activity are only add-on therapies. You have to have something such as carbidopa, levodopa usually as your first therapy that you start, and these others can be added on. Then we have amantadine, and amantadine is a much older drug. It goes by Simitrel and a few other names. And with amantadine, they're not 100% sure how it works, but overall, it may help with the symptoms of Parkinson's disease. So let's start talking about each of those drugs individually. So let's start with carbidopa levodopa. Dopamine itself, if we gave a person dopamine by mouth, the problem is it's not going to be able to cross from your blood into your brain. So whenever you take a medication by mouth, it absorbs through your intestines into your bloodstream. And then if you need it in the brain, it has to cross what's called the blood-brain barrier. And only certain types of drugs can cross the blood-brain barrier. Dopamine is not able to. However, levodopa, which gets broken down eventually into dopamine, is able to cross the blood-brain barrier. And when it crosses the blood-brain barrier, it is going to then be able to have that action of dopamine in the brain. Carbidopa. So we have levodopa and we have carbidopa. Carbidopa is simply a decoy. As I mentioned, there's things such as COMT and monoamine oxidase, which break down dopamine. It can also break down levodopa. So what carbidopa does is it acts as a decoy. While the enzymes monoamine oxidase and COMT are busy chewing away on carbidopa, levodopa is able to escape and make it to the brain. So that allows more levodopa to be available. So carbidopa is only your decoy, and I have my little duck down there to remind us that carbidopa is our decoy duck. So let's talk a little bit more about carbidopa levodopa. Scheduling is very important. For the immediate release, or the ones that release everything at one time when you take the tablet, you may be taking these multiple times a day. They need to be on a schedule, and a schedule that matches what you need them for and when you're having your most symptoms. So when you have on and off periods, when you have dyskinesias, dystonia, and freezing, those are all symptoms that need to be discussed with your doctor. And whenever you have these, it may be happening at the same time every day. And that's what your doctor will be looking for to see if we can in some way change your schedule with your carbidopa levodopa to make it more effective. In studies, they found that Cinemet and Cinemet CR, and Cinemet CR is controlled release or a longer acting type of carbidopa levodopa. It just releases more slowly in the body. It's not necessarily more effective, but it does have an area where it works really well. And that's that Cinemet CR can be used at bedtime to decrease vivid dreams. Sometimes when you take the immediate release carbidopa levodopa, it may cause vivid dreams. With Cinemet CR, you can take it at bedtime. You may not have the vivid dreams or nightmares that can occur. Also, for people that are having off periods in the morning, so it just feels like you're not able to move when you're trying to get out of bed, sometimes at bedtime, Cinemet CR will be given so that the off period is not going to be as strong in the morning when you wake up. So adjusting is necessary with all Parkinson's drugs. So whenever you have these types of items such as peak dose dyskinesia, motor fluctuations, we may have to adjust the medications that you're on. So for peak dose dyskinesia, we may reduce some of the add-on therapies. So if you're taking pramipexole or ropinirole, or any of the ones that are going to inhibit enzymes, those may be areas where we may be able to stop those and prevent the dyskinesias from happening. And finally, we can add some amantadine, and it sometimes helps with peak dose dyskinesia. So that is one of the areas where amantadine, even though we don't 100% know how it works, it does seem to work for this symptom. Dystonia. For morning dystonia, we may do a couple of things. First, we may do the bedtime Cinemet CR, which we just talked about, or add ropinirole or pramipexole. And finally, we have diphasic dyskinesia. And diphasic dyskinesia is going to usually require us to increase the levodopa carbidopa, or to have smaller, more frequent doses of carbidopa levodopa. And the reason that we may have diphasic or two-phase dyskinesias is because we need to find a way to get enough carbidopa levodopa in your body or to help reduce the dystonias. So motor fluctuations are the others, and again, we may increase dose or frequency of carbidopa levodopa. We could add a COMT inhibitor, which is going to extend the action of dopamine and levodopa, or we could add a dopamine agonist. We could add an MAOI inhibitor. So with the MAOI inhibitor, remember selegiline is not really the one that we use as commonly. And then we also have rasagiline, which can be added, and you don't have to worry about dietary restrictions. We may be using an extended release carbidopa levodopa, and that's going to help with the motor fluctuations. And finally, we have rescue therapy. So we have apomorphine injection, which is one which requires an injection. The more interesting product, which is just on the market, is the levodopa aerosol. So it's actually an inhaler that you use, and you get a dose of levodopa carbidopa that you breathe in through your lungs. So it's a little interesting that does exist. It's available through a specialty drug program, the levodopa, and it absorbs through your lungs into your bloodstream. And it does have a relatively quick onset, so that means that when you breathe it in, you're going to get the levodopa into your body much faster than if you took it by mouth. So that is a product that is available. It does take a little bit of extra manipulation of the product to be able to inhale it. So education is key for that product. So make sure you ask lots of questions so that you understand how to use the product effectively.